Thank you for joining us for our Research in Progress webinar today. My name is Chris Battle, and I am Deputy Director at Systems for Action. For folks new to our program, Systems for Action is a signature research program of the Robert Wood Johnson Foundation. We've been charged with building an evidence base for ways to better align the often fragmented medical, social, and public health systems with an express goal of improving population health and advancing health outcomes. To learn more about the studies we support, feel free to check us out on the interwebs on systemsforaction.org. Today we'll be hearing from one of our teams out of University of Chicago. And they'll be talking about strategies for dissemination of comprehensive care physician and comprehensive care community and culture program models. Without further ado, I'd like to introduce our presenters today. David Meltzer is a Fannie L. Pritzker Professor in the Department of Medicine and the Chief Section of Hospital Medicine. We'll be sharing these slides with you afterwards, so I won't read through all of these, but suffice it to say he's quite accomplished. Next slide, please. We'll also be hearing from Harold Pollack, who is a Ross Professor at the School of Social Services Administration and is the co-director of the University of Chicago Health Lab, and also co-founded the University of Chicago Crime Lab. And we'll also be hearing from Emily Parrish. Emily is the Director of Operations and Business Development for the University of Chicago Comprehensive Care Program, which houses the Comprehensive Care, Community, and Culture Program. And Cressa Parrish. Dr. Parrish is a family practice physician at UChicago Medicine, Ingalls Memorial Hospital. So without further ado, I'll turn it over to the presenters, and take note that there is a Q&A box. Feel free to ask any of your questions there, and if time permits, we'll be able to have the presenters answer those questions. And if our speakers are on mute, please unmute. We currently can't hear anything.
This is Cressa Parrish. Can you hear me?
Yeah, Cressa, we can hear you.
Okay. I'm not sure what happened with David and Emily because we could hear them before we went live.
Hello?
Hello?
Can you hear us now?
We're having.
I hear you, Emily.
Oh, great.
There's David. But there's
Okay,
a
great. Did it
beeping
just
going
start
on.
working? Okay. Okay. Sorry about that. There was something when you shared your screen that suddenly we couldn't access our own computer control, so we couldn't unmute ourselves. So that's what happened. So I was just starting to say, thanks everyone for joining. I'm going to talk today about the work we've been doing trying to disseminate our comprehensive care physician and comprehensive care community and culture models. Some of this material folks who are veterans on these calls have seen before, so I'm going to try to go through that rather quickly. And the highlight really, I hope at the end, is going to be an example of our efforts to disseminate. And you may have noticed that Emily and Cressa have the same last name. That's not a coincidence. Cressa is Emily's mom, and one of the wonderful ways Emily has helped us is by facilitating the connections with her mom and Ingalls. And so we'll have a daughter interviewing a mother. So that'll be lots of fun. And Harold and I, of course, will chime in. So as I think folks know, the challenge we're really focused on is addressing the care of complex patients whose care is very often fragmented. And there have been lots of efforts to try to address that through care coordination. And I think people know well that a very small fraction of patients account for a large fraction of health spending and adverse outcomes. We know that there are often multiple interacting health conditions for these patients, and they involve multiple specialists and treatment sites. And so care easily becomes fragmented. We also know that a large fraction of these costs and adverse outcomes are closely tied to hospitalization. And with the advent of a series of new payment models such as ACOs, readmission penalties, and so on, improving care coordination is really a key opportunity, but it's proven very challenging. We have here some figures that show the results of a Congressional Budget Office report of a number of years ago, almost a decade already, looking at the effects of Medicare's care coordination programs. And although some have shown trends towards decreased hospitalizations, almost as many have shown increased hospitalizations. And the conclusion overall is that these really can't consistently be relied on to reduce hospitalizations. And most of these programs involve hiring care coordinators, and the programs seem to work a little better the more coordination, the more communication there is between the care coordination and the doctors and the care coordinators and the patients. But even under the best circumstances, they don't clearly reduce hospitalizations, and moreover, often don't recoup their costs. You can sort of see the problem in a sense on the right-hand side, that is the difficulty in decreasing costs. Right now, we spend some money on ambulatory care, a lot of money on hospital care. We want to shrink the width of that bar. We're not going to do it by decreasing ambulatory care because it's not much and it's keeping people out of the hospital. We have to pay for these care coordination costs because we're adding care coordinators. And that means that if we're going to shrink total costs, we have to dramatically decrease hospital care. And that just turned out to be really hard to do. So that's kind of the dilemma. And can you help me advance? And even though sorry, we're having some trouble here. Even though that study from the Congressional Budget Office is from 10 years ago, there's really been no programs that have really proven effective even during the past decade. So into this mix come hospitalists, physicians who specialize in inpatient care. This is a change from the traditional model where we had primary care doctors who cared for the patients in and out of the hospital. When hospitalists got started, they were hoped to improve care and lower costs. And people highlighted the potential advantages like inpatient expertise and presence, but they were also aware of the disadvantages, including discontinuity of care and erosion of the doctor-patient relationship. And as people have looked at the net effect of hospitalists over time, I would say the basic conclusion is they're zero to modest at best. And yet this hasn't stopped hospitalists from growing incredibly. There are now more than 50,000 hospitalists in the US. And this led us to interest in why hospitalists grew. And one theory is that they grew because even if they didn't actually improve hospital care a lot, people thought they would. And that may be certainly one driver behind it. But we've come to believe that another story is at least as important and maybe more important. And that is that hospitalists grew to meet the needs of primary care. The primary care doctors found that they had decreasing hospital volume compared to ambulatory volumes, particularly as their ambulatory volumes rose with increases in preventive care. And so they just didn't have enough patients in the hospital on a daily basis to justify blocking out their mornings to go see patients in the hospital they had previously done. And so as physicians organized into groups, it was easy to sort of specialize and send perhaps just one of their colleagues off to see those patients. And it's out of that the hospitalist model grew. So this is what we've come to sort of think about why hospitalists grew. And this theory is one that we've actually tested. We've developed economic models of the allocation of physicians' time, emphasizing the difference in time cost between the traditional model where internists see their patients in hospital and clinic and have transport costs between the two, and this new hospitalist PCP model where both the hospitalists and the PCP each spend time just in their respective locations, but now they each have to spend time communicating with each other. And so the difference in cost between these two models is really driven by per capita communication costs relative to transport costs for the typical internist. And when you develop this sort of formal framework, you get a number of predictions about when the PCP hospitalist model is going to grow compared to the traditional model. And that emphasizes falling admission rates relative to ambulatory visits, declines in communication costs, rises in transport costs, and declines in physician hours. In fact, historical trends have been in all these directions. I've already talked about falling admission rates, but better technology for communication, rising scale of hospitals, making transport more difficult, declining physician work hours. And in fact, we were able to get data from the community tracking study and test whether changes in these variables at the physician would abandon the traditional model and move towards a PCP hospitalist model. And every single one of the theoretical predictions was supported by the data. So we concluded that hospitalists grew not because it was better for patients, but really because it was kind of more convenient for doctors. Now, you could just sort of accept that and say that's the way the world needs to be. But what you give up is really the doctor-patient relationship. And there's a rich literature showing how valuable that is in terms of trust, interpersonal relationship, communication, and knowledge of the patients. We know patients value seeing their own doctor in the hospital. There are also observational studies that show Medicare patients have about 15% lower costs if they're seen by their own PCP for more than 10 years. Lung cancer patients cared for by their own doctor in their terminal hospitalization have 25% lower odds of ICU use, which is presumably futile care in that context. And those are observational studies. There's one amazing experimental study by John Wasson in the VA in the 1980s, where he randomized complex patients to see either the same primary care doctor in every visit or a completely different one in every visit. And what he showed is those patients seen by the same doctor in every visit had 49% lower emergent hospitalizations, 38% lower hospital days, and 74% lower ICU days. So really huge benefits. And we conclude from this that continuity is harmful and costly, especially for these complex, frequently hospitalized patients. And it raises the question of whether there's a practical way to restore that continuity in the doctor-patient relationship that used to exist in the traditional model. Okay, so what we came up with was this comprehensive care physician model where we stratify patients according to expected hospital use. On the left, those unlikely to go to the hospital get an ambulatory-based primary care doctor. In the rare instance they're hospitalized, they get a hospitalist, but they don't get hospitalized very often. And in contrast, on the right, those with high expected hospital use get a comprehensive care physician who only sees patients at high risk of hospitalization. So they can have a clinic that's small enough that they can see those patients in the afternoon and yet have the morning free to see patients in the hospital and have enough of their own patients in the hospital every morning to make that worth it. So many advantages to this model. The most frequently hospitalized patients get their own doctor in both settings. This continuity is valued by patients, decreases unnecessary testing, treatment, and errors, lowers the doctor costs. All hospitalized patients get doctors with significant hospital experience and presence. These can even be specialists. Patients can choose their doctor, which they can't with hospitalists. This model can work practically for a physician with a small panel size. You can use this in a patient-centered medical home or bundling or readmission penalties. And if you're a small hospital and you need to fill beds, you can build a small primary care base focused on these complex patients. Bunch of challenges are obvious. Can it be implemented? Will patients switch? Will doctors let patients switch? Will doctors even do this job? Will it work in terms of improving outcomes and reducing cost? And this is where we began this CMMI-funded 2,000-person study, which I'll talk about in a minute. And can it be adapted to different clinical contexts and economic context? And our RWJ program is, in a sense, adapting this to a very highly socially vulnerable population. We'll talk about that in a second. And then a series of implementation studies that are looking at how we do this in different contexts, and Ingalls would be an example of that. These are the key design elements of the program. We focused on these patients at increased risk of hospitalization. We identify them very simply by basically whether you've been hospitalized in the past year or can be found in the emergency room. We maximize direct interaction with the CCPs by keeping the panel size low, and they spend their morning in the wards and the afternoon in clinic. We built a very tight interdisciplinary team at U of C of 5 of these comprehensive care physicians and a very lean multidisciplinary care coordination team, including social work and nursing and so on. We keep the costs of coordination low with small, very well-connected team, multidisciplinary rounds, a lot of provider continuity, focus on care transitions with simple health IT, post-discharge calls. We've worked across a variety of financial incentives, including fee-for-service and shared savings. We try to really support the team through sustainable roles and training. These are very morbid patients. We use rapid cycle innovation techniques with data and engaging the right leaders. And then, as I mentioned, we did a rigorous evaluation with this 2,000-person RCT. I'll very quickly touch on the results. The original CMI study, the intervention and control group beautifully matched in terms of baseline attributes. And then in terms of outcomes, physician ratings start at the 20th percentile nationally in the intervention and control group. The gray bar is the control group, where we get them a new doctor because they're not happy with the one they have, and that gets better. It goes from the 20th to 80th percentile in HCAP scores, and yet the CCP model goes to the 95th percentile and stays there. Here, it goes out to a year. We have similar data out to 2 years. We didn't really see big movements in general health status, basically the same between the two arms, a little bit of non-significant difference at baseline, but nothing striking. And then for mental health, no statistically significant difference at baseline, although there was a little trend for the CCP group to do better. We control for that, and then controlling even for that difference, highly statistically significant improvements in mental health status. Again, here going out a year, but we have similar data out to 2 years. And then in terms of the economics of this, it's really follow-up hospitalizations that are key. No statistically significant difference at baseline, and then as you go out to a year here, you see that hospitalizations for CCP are statistically significantly below those for standard care. That's an absolute reduction of about 7% percentage point absolute reduction per quarter, or about 1/4 hospitalization per year, suggesting a number needed to treat 4. So you enroll 4 patients in the program and you prevent 1 hospitalization over 1 year. So we learned a lot from this original study. It was possible to implement the program. The volumes worked okay. The dean didn't fire me. I was happy about that. And the CCP program improved patient experience and lowered hospitalizations. And it looks like it saves about $4,000 per patient per year. So savings of about $4 million a year for the program over 1 year. A number of limitations. These are self-reported outcomes, which could be biased by patient self-report, but they turned out to be, pretty robust to a variety of statistical techniques to analyze incomplete data. We're awaiting complete Medicare claims data to assess hospitalization and costs. We did have a challenge in executing the program that our dual eligibles were more likely to drop out because of an Illinois state Medicare Medicaid alignment initiative, and particularly the healthier ones. So that creates some challenges in analyzing the claims data. But the most important limitation was it was just one CCP program, one hospital, a limited set of doctors, and for this presentation, probably most importantly, an incredibly socioeconomically disadvantaged population. And interestingly, we found that about 30% of the patients who signed up for the study, having said they were interested, really never engaged. And so our motivation for the RWJ project was to really try to engage those patients. So that caused us to establish this comprehensive care community and culture program with systems for action support. It begins with the CCP program and then adds to it 3 elements. First, systematic screening for unmet social needs, which we screen for using a health leads instrument, access to a community health worker to better engage patients, connect them to resources, and then finally access to community-based arts and social programming to try to activate patients. And all these together are taking the sort of S4A approach of trying to align resources across sectors by identifying and meeting patient needs, ultimately to activate and engage them in their care. This is the conceptual model for what we think we're doing with C4P. We start with a bunch of high-risk patients who may or may not be activated. If they're fairly activated on that top branch and we offer them access to CCP, we think they do better. On the other hand, the patients who are not activated don't have the tendency to sort of engage in their care because they don't feel it can make a difference. They don't really benefit because they don't get involved in the program. We add to that the C4P elements of systematic screening, community health worker, and this arts program to activate the patient. We then hope they become activated, take advantage of the opportunities they have with CCP, and then benefit from the improved outcomes. So what we'll show you is some data suggesting that, in fact, it's these less activated patients who are benefiting most from the addition of these new elements of the model. We did a pilot in our round 1 system for action study, and our goals really were twofold. First, to gain experience operating the program, and then secondly, to do a pilot study comparing outcomes, recognizing it would be quite underpowered. Let me just start with the sort of first aim. When we began, we just had to recruit, organize, and train the team. There was a lot of role definition that needed to happen that was very important. We needed to partner with patients to iteratively improve the programs, both the role of the CHW and the Artful Living program. We also learned a ton from looking at this unmet social need data. And one of the striking things is that we looked at these 17 different domains of unmet needs. We realized that the patterns of unmet needs were highly concentrated. 67% of all the unmet needs were concentrated in 24% of the population who had 5 or more needs. We then recognized that we needed to develop programs that targeted clusters of needs, because we couldn't just refer patients to one program for one need, another program for another. So we did this latent class analysis, and we identified 5 patterns of needs that I'll come to in a minute and talk about each one. But there's basically a very high need group and then a couple of other clusters and a very low need group. And we developed interventions for each of them. Let me talk briefly about the 1-year pilot study. We really wanted to look, as we had in our previous work, at patient experience, self-rated health status, hospitalization rates, and then also this measure of patient activation. And this shows the sort of table 1. Again, things were very well matched overall in terms of baseline characteristics. And then this looks at the effects on hospitalization rates and PAM. And what you can see here, these are odds ratios. The colored ones are where effects are significant. And you can see that C4P, instead of a 15% or so reduction in hospitalization rates, the odds ratio is 0.73. So it's more like a 25 to 30% reduction in hospitalization rates. You'll see the p-values there is 0.15, so not quite significant, but as I indicated, it really wasn't powered for outcomes. But the trend's really striking, and you can see that effect is really coming from the difference between C4P versus CCP. So that's really interesting. The other thing that's quite fascinating is that if we stratified people by PAM, the patient activation measure, those that had a high degree of activation, their odds ratios were pretty close to 1, meaning it didn't look like they were really getting any benefit. And yet those who had low activation, that's where the real benefit was coming from C4P versus CCP. The other thing so this really supports our theoretical model. The other thing I'll point out that we thought was fascinating is that activation increased in both arms, both in the C4P arm and in the CCP arm. And we take that as evidence that these relationships with the doctors are really critical, and that the core social work team are really critical to driving improvements in outcomes. So for next steps for this, we're finishing the analysis of these 2 programs at the University of Chicago. For CCP, we're focused on longer term follow-up, looking at costs, duals and non-duals, stratifying by hospitalization risk, looking at the doctor-patient relationship issues and end-of-life care. For C4P, we're completing the analysis of the unmet social needs, including changes over time, and also there looking at outcomes and claims. We were funded by RWJ for a phase 2 study, and in that phase 2 study, we took this latent class analysis and developed interventions that look at the clusters that you see here on the bottom, a many basic needs group, a healthy living and social engagement group, a health and financial group, and a child-related group. And for each of these, we developed targeted interventions. The most ambitious of these is what you see, the Social Service Alignment Learning Collaborative. Emily really runs that. And it's about bringing together all these social service organizations using a case-based method to try to understand how they can learn more about each other, but also work to serve the needs of these very complex patients. And again, one of the conclusions that's coming from that is the incredible importance of relationship-driven care. Then for the other clusters, healthy living and social engagement, we're doing like a community garden. For health and financial, insurance and financial, we're doing financial counseling and other things. Harold's really critical for that. And then we have a small child-related cluster where we really just use targeted social work. We're pleased to say we've just gotten notice that we will be getting funded by PCORI to do a really definitive, very large trial comparing C4P, CCP, and a sort of care coordination model. And that'll be 1,000 patients per arm. So the RWJ phase 2 study is the first set of patients going into that cohort. And when the RWJ funding ends, the PCORI funding is going to kick in to help us continue that onward. As we've been doing all this, we've really been trying to begin to think, how do we disseminate this and how do we implement this in various settings? And you can see here a tool that we've developed in partnership with students in the Harris School, and Emily was part of the first cohort to work on this, looking at various domains that we think are critical. Can you find the right patient population, these patients at high risk of hospitalization? Can the hospital support this sort of complex team? Do we have clinic space that works? Are we able to have the human resources support we need to hire these people? Can we get buy-in at the health system to do this? Do we have social needs in the community and strategies to address them? And finally, do we have aligned financial systems? So as we started to think about working with institutions, we've used this tool and this sort of spider diagram to help think about how we're doing in various dimensions, and are things ready to go, or are there things that need to be adjusted before we could think about doing this? We've learned that this sort of work, as we start to do it, is intensive. So, and our ability to do it within the traditional academic setting is limited. So we've recently started a 501c3, the Comprehensive Care Institute, to try to spread this. We went through the National Science Foundation's I-Corps and leveraged media attention and things like this to try to grow this. Our mission really is to promote the adoption and continual improvement of these models that try to integrate the strategies to address the medical and psychosocial needs of patients. So we're partnering with health systems in the US and internationally to try to spread this. We're trying to convene individuals and organizations interested in this idea of comprehensiveness of care. And ultimately, we want to support the further studies of these models so that we can learn how to better do them. Give you some examples of some of the dissemination efforts. Large system stuff. Here at the University of Chicago, we continue to explore new models. One is the Rounder model, which is a version of CCP that's more focused on continuity across hospitalizations, also working with patients who are coming from far away. We're working with Rush here in Chicago and North Shore to try to explore possibilities there. We've partnered in the community. We have a version of our CCP program that's working a little more with FQHCs WHCs, which are more economically viable in terms of Medicaid. We've started developing a CCP program at Ingalls Hospital. You'll hear from that in a minute from Cressa and Emily. And we're working with other Chicago area community hospitals actually quite intensively to try to do this. And these tools that I've shown you have proven very valuable there. Nationally, a number of large systems have either built programs like Vanderbilt and Kaiser in the Mid-Atlantic region. We've been talking to UC Denver Health, and we're in early stages with several other systems. We've been working with payers. We've done and now renewed a payment model with the city of Chicago, which is very exciting. CMS voted to recommend a physician-focused payment model to support the growth of CCP. We're sort of stuck in limbo with CMS, but we're still hoping. We're sort of working on some models similarly with Blue Cross Blue Shield. One of the areas we're very concerned is risk adjustment, particularly in risk-based contracting. Finally, internationally, we've been working with National University Singapore, in the UK, in the National Health Service with the Frimley Trust. They've both developed programs, and then Manipal University in India, where we're sort of studying some programs there that have interesting similarities. So that's kind of where we are. Let me turn it over to the two parishes, and they can share the experience at Ingalls.
Great, thanks, David. Some context at Ingalls. So Ingalls is a community hospital located in Harvey, Illinois, which is directly south of the southern border of Chicago, a city that boomed in the 50s, 60s, but has struggled economically significantly since. And Ingalls really serves as sort of an anchor institution, the largest employer in that community, and has been a great testing ground for scaling and learning techniques and best practices to the core elements of CCP and specifically C4P models to other settings, particularly community hospital settings. So I'd be curious to hear a bit more. We know our experience, but Cressa, from your experience, the need for complex care models like C4P in community hospital settings like Ingalls, and the need for models that sort of support longitudinal relationships, both from the patient's perspective, but also from the physician and systems perspective.
Sure. Well, I've been a physician for 34 years, and I've been in family practice the entire time, and I've been at Ingalls Hospital the entire time. So I have quite an allegiance to the area and a fully developed practice over all that time, starting with newborn patients all the way through end-of-life 100-some-year-old patients. And I can definitely vouch for the value of having a bond and a long-time relationship with those patients in its contribution to their overall health. I would say that since hospitalists have become available at Ingalls, we have been required to use them for Blue Cross Blue Shield HMO Illinois patients, so I can see some difference in my management of a patient who uses the hospitalist in the hospital versus myself in the hospital. But I do continue to make rounds on my patients when that's allowed by a healthcare contract. And definitely the patients are excited to see me when I come in the room as opposed to a hospitalist. Only not because the hospitalist is providing inferior knowledge to the situation, but just the lack of trust and any prior relationship, which would be helpful in determining what the goals for the patient are, what the known outcomes have been in the past for the same sort of treatment options for maybe the same condition that they've had for the last 10 or 15 years, and buy-in from the patient as to the treatment plan that is being recommended. It's a much smoother process if the patient already has a level of trust in the provider as opposed to meeting someone new each time they come in the hospital. So I think that trust is invaluable. I would say the recognition of frailties in regards to finances, transportation, food, insight that the patient may have or lack thereof into their illness list is, I think, very helpful information in managing their hospital stay, as well as hopefully keeping them out of the hospital going forward. Can you all hear me okay?
We can hear you.
Am I still audible? Okay, it got really quiet. Also, there's an ability, I would say, to coordinate the care of all the conditions in a way that fosters overall best health outcome. And I feel it's easier to develop a consistent plan of care and interact with the specialists who are caring for that patient if the specialists and the primary are all involved both in the outpatient and the inpatient setting. The other thing that I think is maybe helpful is that I have the big picture in mind for their overall health, and so I might be more tending toward coordinating methods for disseminating topics that might provide health and education to patients, such as the topic of obesity, which may then impact their diagnosis of diabetes, hypertension, their kidney function, their inflammatory state of their joints. I mean, I like to use the example that I'm looking at the elephant. I'm not looking at a part of the elephant. So I can see this as an elephant and not as a leg or a trunk or a tail or a tusk or something. So I feel like that's helpful.
Great. And building on that and building on, wanting to maintain relationships and trust with patients, particularly where there are complexities around both medical conditions and potentially social needs. We've been, or you all have been, with 3 other physicians implementing the C4P model since around June of 2019. Can you talk a little bit about what the experience has been to adapt elements of that model to Ingalls? What seems to be working well? Where do you want to continue to focus?
Well, we have two right now AmeriCorps members who are going around interviewing the patients to see if they're interested in the program, and the questions that are being answered definitely give a nice picture of the overall goals for the patient for their health, as well as gaps in their ability to access that care. As I mentioned, either due to cost of drugs or lack of transportation to the visits or testing, or maybe not having great access to healthy foods or insight into their illness so that they can understand why something is important to implement. I would say that the communication that we get from the AmeriCorps workers to our office then via an email that summarizes that interaction once they've enrolled in the program is helpful. We're working toward having an integration with the care coordinators that are employed by the hospital, because we feel that our questions are going to supplement what they already know as opposed to being redundant, and would be helpful to them in planning their discharge arrangements. So I think that's going to be helpful. In my role as the Associate Medical Director for the ACO for Ingalls and also the Ingalls Provider Group, which is the HMO setting for several insurance companies that we contract through. Those will benefit from us recognizing gaps more robustly and being able to communicate that back to the physicians who are caring for those patients. I don't know, David, it didn't seem that you mentioned a rounder model in your presentation, but we've been trying to adapt that at Ingalls because we have some concerns about whether patients will want to switch to a different physician or whether that's even something that's a good idea. in the case of someone who's frequently readmitted. And so we have a group of physicians who are employed by the hospital. I am one of them as of September. And so we have just in the last week started, and I was the first one to take call this past weekend for this group, but we have a group of approximately 15 physicians, most of whom, I'd say 2/3 of whom see only outpatients and 1/3 of whom see inpatients. And we have decided that we will round for the patients who will see their outpatient physician in their office, but that physician doesn't want to make inpatient rounds for the very reason that David was mentioning, that it doesn't seem to be cost effective for them to go to see a few patients and block that time that they could be seeing people in their office. And then we will be more familiar with those patients as opposed to a hospitalist setting where they're rotating randomly depending on their hospital admission. So we feel that we're able to create at least a more familiar face and much more intimate knowledge of those patients and be able to communicate more effectively with their primary care physician, in addition to actually implementing specifically the CCP model for the 5 of us who are rounding in the hospital, so that we'll see patients typically in the morning and then clinic in the afternoon.
Great. And I know we want to keep some time for questions, so I can ask one last one unless David and Harold have others. I'm curious if you touched on this a little bit, particularly in your role with the ACO and then dually working as a CCP physician in the C4P program at Ingalls. Do you have a piece of advice or an insight that you think is worth sharing with other providers or institutions who are increasingly moving towards risk-based environments or in risk-based environments and are being held accountable for reaching these benchmarks of quality and are considering different population health interventions to implement, particularly in sort of the complex medical and social need space? What types of things do you think they should be thinking about?
Sure. I think the thing that most attracted me to this model was my perspective on cost savings and better patient outcomes of health. And I strongly believe, and David's able to provide data that show even at an academic setting, which will tend to have even more complex patients than most community hospital admissions will have, that there are cost savings and that they're significant. And so, of course, the smaller the institution, probably the more that proportionately will be an advantage to any ACO looking to share downside, upside risk with their patient admissions. I think there's a challenge on the part of hospital administrations to be willing to take the chance that they're going to have shorter stays, lower volume admissions, and that is going to be a financial reward to them somehow when it seems contradictory. And I think we need a very nimble and robust and integrated system especially in a community hospital where resources may be more sparse, to be able to tie all that together to react quickly when we see trends. And I think that this model is a way to be communicating maybe with a group of physicians who are already very intimately tied to the outcomes that the ACO would be desiring.
Cressa, can I just make one comment? I really enjoyed listening to you and Emily talk. One of the things that we've managed, which has been complex, is sort of the politics of patient allocation and existing practice models and the hospitalists and concerns of all of that. I think our response to it has been to be very sensitive to those things and kind of go slowly and take advantage very much of your like very keen insights into your colleagues. If you were talking to someone at another community hospital who was thinking about this sort of intervention, are there any lessons you've learned from the process of trying to sort of make it happen that, you know, maybe weren't obvious to you at the beginning?
Well, I think it was difficult for us because we had multiple transitions in the top management of the hospital that just kind of happened to coincide with implementing the C4P program. So we explained ourselves to multiple CEOs, which made progress somewhat difficult at first, but I think more recently we've been able to navigate the system better because we have just sort of focused on physicians who are already wanting not to admit their patients to the hospital or see them in the hospital, and are interested still in the best outcomes. And I think it's easier for them maybe to see that this would make sense. And we're very careful to continue to involve them in everything that's happening with the patient. I would say, you know, sign out that I made on Monday, I made to the physicians who were in their offices, not only, you know, to the people who were going to make rounds on those patients. So I think if you can include everyone, and if everyone can see the advantages and see how even as a physician it's impacting in a positive way their ability to use their time most efficiently and get the best outcomes for their patients, then I think it seems to be a much smoother transition. Does that help?
I guess.
Great. So maybe it makes sense to spend the rest of the time on questions.
There's one question. You guys have a thought about how to answer this question about the Camden?
Yeah. You want me?
Yeah, why don't you go first and then I'll chime in.
Yeah, we did get one question online. It was about sort of the negative findings of the New England Journal of Medicine study on the Camden Coalition intervention that was published recently. And, you know, I'll add the question sort of like, you know, what do you think might be, why might your program be working when that one didn't? And I think the big thing I would emphasize is this sort of durability of relationship. The fact that, you know, we're a much longer term intervention, that was a relatively short term one. I will tell you that when we've analyzed some of our data from our original CMS study, one of the things we see is that the benefits are most rapid in the traditional Medicare population, and in the dual eligibles it takes longer. In fact, there may even be some increase in utilization initially as we begin to address unmet social need. There's also the problem of lack of engagement, which our C4P intervention is addressing. Obviously, the Camden folks are trying very hard to engage people. So I think those are some very important parts of the difference. I will point out that one of the reasons the Camden interventions and many care coordination programs are short-term is that they're costly. And, you know, why can our program, you know, not have such a short time frame? It's because rather than hiring a lot of new people, we're trying to defragment the care so that rather than more total care, it's a larger fraction of the care from a given, you know, person, which then builds trust. And, you know, I've often come to feel recently that adding a bunch of care coordinators and other people, including community health workers who come and go and don't have established relationships with patients, can be destructive. At the same time, it's constructive. You know, now we do have community health worker involved in our program. We have social work, but they are integral parts of our team, and we try very hard to keep them stable. But at the core of it is this stable relationship with a provider. And I think that's really central to this.
This is Harold. I'll just say this is actually not a contrast with C4P, but on the Camden results, I was at the annual social work research meetings, and Heidi Allen was on a panel where the same question came up. She's a social worker who was the lead author on some of the Oregon health insurance experiment studies. And one of the points that she was making was a lot of what needs to happen in interventions like, as in the Camden Coalition, is referrals to services that don't always exist. And she said, the social workers, community health workers are not, not magicians. And one of the challenges that we've had in other interventions in Chicago is that people come forward with needs that our outreach staff and our CHWs really can't meet. There's long waits for housing, and some of the needs that they have there in the social determinants area are hard to address. So the C4P seems to be more aligned with things that are actionable in a realistic way within the environment.
Yeah, I mean, I want to say one thing about this. I do believe absolutely that there are things that there are needs that people have that the interventions can address. I also think that there are aspects of many of these vulnerable people's behaviors that make it harder for them to take advantage of things even when they exist. And it is not a matter of the CCPs writing a referral. It is a matter of continued repetitive engagement to help people feel like they actually can do these things, and literally sometimes driving them over there or being with them, and then whatever, there's constant entropy in these systems, right? So when things start to fall apart, being there so that they don't fall completely apart.
And I also that sometimes the social worker, I almost feel like there's a burnout on their part, that they feel they don't see the outcomes improve necessarily in the current system, and so they tend to hand out a list of options that are available. But honestly, if the person doesn't have clear motivation to access someplace on this list, then there may as well not be a list. And so I think when they're following up with their physician who is invested in this and is saying, this is, my main concern is that you don't seem to have much in the way of food. You're going to convenience stores all the time, and you have CHF, and you have diabetes. And so I got into the nitty-gritty with one of my patients who was getting no food for 3 days. Now, if that hadn't been recognized, it would have gone untreated and unaddressed, and handing them a list of food pantries doesn't really help. I think most of them know there are food pantries. There was a reason they didn't access that in the first place. So I feel like it just creates a more intimate relationship that is more functional and comes up with outcomes that are more desirable.
That's great. We have 2 more questions here. One is, do we have any tools to measure relationships? We have a couple of different ones. We have tools for the relationship between the patient and the provider. So there are things that measure trust, knowledge, communication, interpersonal relationship. We have questions like HCAHPS type measures that look at the interactions between the support staff, like, the people answering the phones and the patients. We then have tools that measure the relationships between patients and their support systems, where those are family, friends, or community. So those are some of the things. We also look at the relationships among organizations to some extent in the Social Service Alignment Learning Collaborative. So those are also understood. And then there's a question, how are we tracking social determinants of health, and how do we use those data? So you saw a little bit of it already with the unmet social need data. The instrument we use is the original Health Leads instrument. It's not the new one that they use. Some researchers gave them a bunch of much more specific questions than the older one, and we like the older one because it's much more broad. It just sort of helps us get a hint as to what's going on, and then we dig deeper. We added one dimension to that instrument because it was missing, which was spirituality. So that's the main thing that we use for measuring it. And then we follow them quarterly and look at changes over time. We've used these latent class analyses.
Yeah, and as we follow them quarterly, anytime a patient says they have any magnitude of need in one of these 17 domains, then automated emails sent to our community health worker and social workers. And so that triggers them to reach out to the patient, start a conversation, open up a case, and kind of document where it goes from there.
Yeah, and I'll just say, you know, we do our best to try to be systematic about how we approach things and organized, and you know, we try. But I really do want to emphasize that in the end, I think what makes this program tick is these relationships. You know, between the patients and the providers, between the members of the team, and that's all heavily reinforced by repetition. It's the repeated return. Every hospitalization is not just kind of a failure to manage disease on the outpatient setting, but it's an opportunity to re-engage with the patient and their supports and figure out how to do it better, rather than being, you know, a anonymous relationship with a new provider who knows nothing about you.
The role of nurses in the model. Anything to say about that?
The role of nurse. So another question: the role of nurses in the model?
Yes, I don't see. My concern is I don't see the role of nurses in your model.
Okay, yeah. So we have RNs and LPNs who are in clinic, and also medical assistants who are there, and they are involved in answering phone calls who come from patients, prescription refills, rooming patients. We've had at times an APN in the outpatient setting. We also have an APN at home who does home care now. We've done home care over time through kind of a hybrid between physicians and APN. Right now, it's an APN. She, in some sense, is sort of like the ambulatory counterpart with a rounder. So she's partnered with a particular one of our CCPs. That's been very helpful. I think those are the main roles of nurses.
Can I make a comment on that as well? I think that it's still very important that the physicians remain directly engaged with the patients. I think these are complex patients that sometimes can be a challenge for the nurse practitioner in regards to innovations in treatment. I think the nurse practitioners are excellent at developing bonds and staying dedicated, doggedly making sure that the patient is taking their meds the way they're supposed to, and coming and checking their vitals and following up on weights and blood sugars and all of that sort of thing, and are able to follow protocols that will maybe be a change in a medication that's predictable. But then when there needs to be more thinking out of the box, I think sometimes I've had experience with nurse practitioners, even of specialists like cardiologists, where it tends not to be quite as good an outcome as I would have hoped, and I have sometimes demanded that a physician be involved and not the nurse practitioner in that case. And I think that's a part of the success for C4P, is that these physicians are directly engaged and stay engaged, and then can provide all of their training and knowledge and thought processes to the situation at hand, which is what some of these more complex patients need. They're very challenging.
Great.
That's great.
Good. Good. Any other questions, anyone? No? Anyone there?
Well, in the interest of time, we'll go ahead and wrap this up. Thank you so much. Cressa, Parrish, and also David and Carol, who I really appreciate you guys taking those questions at the end. Made my job a little bit easier. It was a pleasure to sit back and listen. So we'll be sharing these slides. A lot of people asked for the slides. We'll be sharing those slides with you via email, and also a recording of this webinar will be available at systemsforaction.org. So we'll see you all February 19th for our next research in progress. We will hear about improving population and clinical health with integrated services and decision support. Thank you all, and have a great day.
Take care. It's great to participate.
And thank you. Thanks, Cressa. Thanks, Emily.
Thank you.
Okay. Thanks, everyone. Great. Bye-bye.
Bye.